It's a pleasure to be with you all again and to provide yet another update on COVID-19 therapeutics. It's amazing we're just 6 or 7 weeks from the virtual CROI where we heard so much new information about COVID-19, and yet in that short period of time, there's been incredible additional progress on the therapeutics for SARS-CoV-2 infection. These are my disclosures. I'm going to cover 4 topics today. I'll provide an update on how COVID-19 has had an impact on mortality in the United States during 2020, provide some additional information on the data regarding the use of Remdesivir, provide an update on the use of COVID-19 convalescent plasma, and discuss new information on the combination monoclonal antibodies casirivimab and imdivimab, both for treatment and prevention of SARS-CoV-2 infection. Let's start with the impact of COVID-19 on mortality in the United States last year. These data are provisional data from the US Centers for Disease Control and Prevention, showing that there were nearly 380,000 deaths from COVID-19 during the period from March through the end of December. As you can see, the vast majority of those deaths were in older people, with the largest number being in people age 85 and over. There were more deaths among men than among women, and there were disproportionately more deaths among Hispanics and among Black non-Hispanics. This figure shows you overall deaths and deaths including COVID-19 deaths. And you can see how they tick up just at the very end of March as the pandemic was recognized here in the United States and continue with an ebb and flow that corresponds to the initial surge, then the summer surge, and then reaching new heights in the surge that occurred during the winter of 2020. You note that deaths from other causes remained relatively stable throughout the year, making the case that most of the excess mortality that was observed was due to COVID-19. COVID-19 had a dramatic impact on the causes of mortality in the United States, becoming the 3rd leading cause of death during 2020. But COVID-19 was not the sole cause of excess mortality. Mortality in the United States increased nearly 23% in 2020 compared to previous years. COVID-19 accounted for just over 70% of those excess deaths, but there was also increased mortality due to Alzheimer's, heart disease, and diabetes, presumably because people were unable to access medical care in the setting of the COVID crisis. Deaths among non-Hispanic Blacks accounted for nearly 17% of the excess mortality, even though this group constitutes only about 12.5% of the US population. And you can see in the graphs below that there were different patterns to these surges in excess death in different parts of the country. New England and the Northeast experienced the greatest increase in deaths during the initial surge in the spring of 2020, but then did a fairly good job of controlling the epidemic throughout much of the rest of the year, although there was a bit more of a surge towards the end, but this occurred mostly in younger people, therefore there were fewer deaths. By contrast, the Southeast and the Southwest of the country, which were largely spared during the initial outbreak in the spring of 2020, saw dramatic increases in the summer and again in the winter. Similarly in the plains, the Rocky Mountains, and the far west. And then the Great Lakes region, which includes Michigan, which is currently experiencing yet another surge, had a significant increase in mortality with the initial outbreak, did well over the summer, and then had a dramatic outbreak again in the winter months of 2020. Well, let's turn now to talk about new information on Remdesivir. A meta-analysis was published just a few weeks ago by Kaka et al. In the Annals of Internal Medicine that pooled data from 4 different randomized trials. These include the ACT-1 study from Beigel and colleagues, the original placebo-controlled trial from Wuhan by Wang et al., the SIMPLE-2 study, which was the Gilead study in people with moderate disease that compared 2 lengths of treatment with Remdesivir versus placebo, and then the solidarity study. And what you can see is that overall, using a fixed effects model, they're looking at mortality. There was a trend towards a reduction in deaths, but that did not achieve statistical significance, and the effect was relatively modest. The relative risk is only 0.93, which represents only a 7% reduction in mortality. If you parse the data based on characteristics of the study participants at the time of randomization, you can see them grouped either by no supplemental oxygen at baseline, requiring supplemental oxygen but not yet ventilated, or requiring ventilation or ECMO. For those who required no oxygen, and again, this is the mortality endpoint, there's about a somewhat greater than 20% reduction in relative risk of death that does not achieve statistical significance. However, among those who did require supplemental oxygen but were not yet mechanically ventilated, there was a 19% reduction in relative risk of death that did achieve statistical significance. Whereas for those who were already ventilated or receiving ECMO at the time that remdesivir treatment was initiated, there was no benefit, perhaps a slight trend towards harm. Looking at non-mortality endpoints, if we examine the proportion recovered, and here the side of the vertical line that favors remdesivir switches from graph to graph, so that's a little bit confusing, but for the proportion recovered, now being to the right side, favors remdesivir, and we see that there's about a 10% better relative risk of improving, which is statistically significant for those who received remdesivir. If we look at progression to requiring mechanical ventilation or ECMO, so this excludes anybody already ventilated at the time of randomization, we can see that in the fixed effects model, there's about a 30% reduction in the risk of progression to mechanical ventilation, which is statistically significant. But when the solidarity trial is included, which is the largest number of study participants, and here excluding those already ventilated at entry, then that effect disappears, or that benefit disappears. And then if we look at occurrence of one or more serious adverse events, there's clearly a benefit favoring remdesivir, and that is statistically significant, about a 25% reduction in the occurrence of SAEs. Let's talk now about COVID-19 convalescent plasma, or CCP. As you know, convalescent plasma is plasma obtained by pheresis from patients who have recovered from COVID-19. These are individuals who may have neutralizing antibody at different titers, and this antibody can be used for prophylaxis or for therapy, given as unfractionated serum. And convalescent plasma has shown some benefit in the treatment of avian influenza and H1 influenza, as well as another coronavirus infection, MERS. And pilot studies and a number of trials have suggested a possible benefit of CCP in the treatment of COVID-19. But this has been quite controversial. A number of randomized clinical trials have shown no benefit, some have shown some benefit, and now the largest study to date, the recovery CCP trial, which recruited more than 16,000 patients, nearly 11,600 of whom were randomized to receive CCP or placebo, showed absolutely no benefit. And you can see here from the Kaplan-Meier plot, looking at mortality, that there really was no difference over 28 days in mortality. And that was true whether you looked at different age groups, whether you looked at gender, race and ethnicity, days since symptom onset, the respiratory status at study entry, whether people were using corticosteroids or not. And in this study, the vast majority of participants were on corticosteroids. And then also whether participants had a positive SARS-CoV-2 antibody test at the time of randomization. So you can see overall, the relative risk is 1.00, showing absolutely no difference between CCP and placebo. In addition, there's been a meta-analysis that pooled data from numerous clinical trials of various sizes. Here, points to the left of the line indicate the benefit of CCP, and points to the right of the line favor control. And we can see that in the summary of all studies, there is no net benefit. But what we note here is that the individual trials contributed different weights to the analysis, with the recovery trial, since it was overwhelmingly the largest, has a disproportionate impact on the results of this meta-analysis. So there were a couple of studies that had a trend towards a benefit, such as the COVID trial, but actually don't achieve statistical significance in this analysis. If we look at length of stay instead of mortality, again, we find that there is no benefit overall from the administration of COVID-19 convalescent plasma. And if we look at progression to mechanical ventilation, here limiting the analysis to participants not yet intubated at the time of entry, we see that there are trends in some trials towards a benefit, but overall no statistically significant benefit. Once again, different trials having different weights. And in this case, the Solidarity trial is not included. I'm sorry, the recovery trial is not included because people could have been intubated at entry, and I believe around a quarter of them were. Now, since Professor Lacombe is another speaker in today's program, I'd be remiss if I didn't point out that there may be specific populations in which a CCP may have a particular benefit, and that includes its use in patients who have received therapy that leads to depletion of B cells, such as treatment with rituximab for lymphoma and other malignancies. In this paper published last November by Professor Lacombe's group, you can see that this was a series of 17 patients who, 15 of whom had received anti-CD20 therapy. And they received their convalescent plasma about 4 months after having gotten anti-CD20 therapy. The majority of them were WHO severity score 5 or 6, meaning they required a supplemental oxygen or high flow oxygen. The time from the onset of COVID symptoms to treatment with convalescent plasma was just under 2 months. These are people who had prolonged or persistent shedding of SARS-CoV-2. And overall, 16 of the 17 participants survived with an average length of stay after receiving convalescent plasma of about 7 days. Let's turn now to talk about monoclonal antibodies, particularly the combination of casirivimab and imdevimab. This combination, which is also referred to as REGEN-COV, has recently posted results of a phase 3 trial. These are not yet peer-reviewed. This is not even a manuscript on medRxiv, but important data nevertheless. This was a study that enrolled adult participants who had confirmed SARS-CoV-2 infection, were symptomatic, but less than 7 days from symptom onset, and were not hospitalized. And they were randomized in 2 different phases of the trial to receive either 2 doses of this combination monoclonal at a high dose, 8,000 milligrams or 2,400 milligrams versus placebo. And then subsequently, the study was modified to use much lower doses. So the 2,400 milligram dose was retained, but then a new arm was added with just 1,200 milligram dosing. Individuals, in addition to having symptomatic disease, had to have at least 1 risk factor for severe COVID that included either being over age 50 or having one of the more traditional risk factors for severe COVID-19 in terms of other comorbidities. And follow-up was for 29 days to determine progression to requiring hospitalization, emergency department visits, or other adverse outcomes. What you can see in these results, and here the two upper panels show the data for the 2400 milligram group versus placebo, and then on the right, the 1200 milligram group versus placebo. Really quite a dramatic effect with the benefits of the combination antibody being apparent within days of its infusion. And looking in the bottom panels, we can see that there was a dramatic reduction in the risk of death. There were no deaths in the people who received the antibody, regardless of which dose. The benefits were statistically significant for those with the highest baseline SARS-CoV-2 virus titers in nasopharyngeal swabs, but the direction of benefit was still the same with those with lower virus loads, and the benefits were observed whether people had presence of had absence of antibody at entry or had antibody present, although statistically significant for those who were seronegative at entry. In terms of days to symptom resolution, there was significantly shorter times to resolution for those who received the antibodies at either dose compared to placebo. So the antibodies in blue, the placebo in red. Again, regardless of whether they had low or high virus loads, the antibody group benefited with a shorter duration time to resolution of symptoms. And that was also true whether they were seronegative or seropositive at entry, although the significance was most evident in those seronegative at entry. This combination of antibodies has also been used as post-exposure prophylaxis. These are data that were, we saw preliminary results presented at CROI, and now the complete results have been released, although again, not yet published. So this was a phase 3 randomized double-blind trial of casirivimab plus imdevimab to prevent COVID-19 in household contacts. The participants were people with without SARS-CoV-2 infection who were sharing a household with somebody diagnosed with COVID-19 within 4 days of enrollment. So this was really very rapid enrollment from the time that contact was diagnosed. There were just over 1,500 participants randomized equally to receive either a single dose of monoclonal, 1,200 milligrams of each antibody, or a placebo. This was administered subcutaneously, which is a big advance over the need to administer intravenously, although several injections were actually required to deliver the 1,200 milligrams of the two antibodies. And this was a trial that was co-sponsored by the COVID virus prevention network through the National Institutes of Allergy and Infectious Disease. You can see the study design here, one-to-one randomization. There were two different cohorts. I'm going to speak today about the cohort that was negative at study entry. They also had a second cohort, those who turned out to be positive, and this cohort is still being followed to see whether receipt of the antibody prevented progression to symptomatic or disease or in COVID-19 requiring hospitalization. The assessments were the proportion of participants who developed positive SARS-CoV-2 test, whether symptomatic or asymptomatic, during the month following administration of the antibody. They had regular testing of nasopharyngeal, oropharyngeal, nasal swabs or saliva, and of course safety. So if we look at the primary endpoint through day 29, there was an 81% reduction in the risk of acquiring SARS-CoV-2 infection in the group that received the antibody cocktail. If we look just 1 week after receiving the antibody, there was about an 18% reduction in, 72% reduction in the risk of SARS-CoV-2 infection, presumably because in the first few days, people who were already infected in the first few days after getting their antibody, that wasn't going to have a big impact. So it took time for the impact to become evident. And then if we look 1 week beyond infusion, there was a much greater effect with a 93% reduction. There was overall a 93% reduction in the weeks with symptoms, as well as a 90% reduction in the number of weeks with high virus loads, here defined as having more than 10,000 copies per mil in the nasal or oral oropharyngeal swabs. There were adverse events that occurred in 20% of the antibody recipients and about 30% of the placebo group. SAEs occurred in 1% of each group. There were some injection site reactions, but these were relatively infrequent, occurring in 4% of the antibody group and 2% of the placebo group. I wanted to make a comment about the impact of the mutations in these newly circulating variants of concern on the susceptibility to this combination of antibodies. We know that these antibodies have that these mutations may have a dramatic effect on susceptibility to bamlanivimab, another monoclonal antibody that is given in combination with etesivimab. But for this combination of antibodies, particularly the B1351 and the P1 variants, which carry the 484K mutation as well as the 501Y mutation, there is no change in susceptibility to the combination of the antibodies. We don't know what the impact may be on the individual antibodies because those data have not been presented. Let me just close by commenting very briefly that there were 2 other important negative trials that I don't have time to cover today. One showing no evidence of any benefit of ivermectin, and the other showing that anticoagulation with high-dose heparin was not beneficial and may have been somewhat harmful. We may be able to get to some of those points during the question and answer period later on in the program. So I will turn this back to the moderators and thank you for your attention.